Thank you for participating in the BC Technical webinar series. Today we will discuss how to better understand radiation dose in CT. This webinar session is worth 1 voice credit. In order to receive this credit, you must complete the online test, which will be available immediately after this webinar. A passing score of 80% is required for the voice credit to be awarded. You may take the test more than once if need be, and a certificate will be emailed to you at the close of this webinar and following successful completion of the online test. Please keep this certificate as proof of your completion of this webinar. The goals of this presentation include defining radiation exposure and terms used when discussing radiation exposure to patients, understanding the sources of radiation exposure in today's CT systems, to understand the ALARA principle in conjunction with producing diagnostically significant images, to understand the role of the technologist and radiologist in limiting radiation dose to patients, and to describe strategies for limiting patient radiation exposure. The following are some facts regarding the background of CT scanning. The benefits of CT to the practice of medicine are indisputable. However, concerns regarding increased cancer risk from CT continues to escalate. Although CT accounts for only about 17% of imaging examinations, CT is reportedly responsible for almost half of the collective effective dose for medical procedures in the United States. According to risk projection models, in a few decades, 1.5 to 2% of all cancers in the United States may be a resultant to the use of CT. Cancer risk from CT may no longer be theoretic, because for the first time, due to recent study reports, a direct increase in cancer rates are related to radiation exposure from CT. CT technologists and radiologists should adhere to both the principle of ALARA, which means as low as reasonably achievable in regards to radiation dose, and the principle of AHARA, which means as high as reasonably achievable when referring to benefit. The objective is to achieve diagnostic quality images addressing the clinical concern in the most dose-efficient manner. Equipment manufacturers continue to make progress toward automating CT dose optimization. Technologists and radiologists must accept the primary responsibility for minimizing radiation dose to patients from CT. To apply dose reduction strategies in body CT, technologists and radiologists must know how to interpret radiation dosimetry data available on a CT dose report and understand the effects of key CT technical parameters on patient radiation exposure. Let's take a look at some key concepts. These concepts include exposure, absorbed dose, equivalent dose, and effective dose. Exposure refers to the intensity of an X-ray beam. It is a measure of the ability of an X-ray beam to ionize air. It is best understood as the number of X-ray photons passing through a given area and is usually measured using an ionization chamber and an electrometer. The absorbed radiation dose is the amount of energy absorbed per unit mass at a specific point and is measured in grays. 1 gray is equal to 1 joule per kilogram. Absorbed dose is the fundamental quantity for describing the effects of radiation in a tissue or organ. Absorbed dose is the energy deposited in a small volume of the matter or tissue by the radiation beam, passing through the matter divided by the mass of the matter. Absorbed dose is thus measured in terms of energy deposited per unit mass of material. Absorbed dose is measured in joules per kilogram, and a quantity of 1 joule per kilogram has the special unit of Gray in the International System of Quantities and Units. In terms of the older system of radiation quantities and units previously used, 1 Gray equals 100 rad, or 1 milligray equals 0.1 rad. Equivalent dose measures biological effects of an absorbed dose of a given magnitude dependent on the type of radiation delivering the energy. That is, whether the radiation is from X-rays, gamma rays, electrons, alpha particles, neutrons, or other particulate radiation, and the amount of radiation absorbed. This variation in effect is due to the differences in the manner in which the different types of radiation interact with tissue. The variation in the magnitude of the biological effects due to different types of radiation is described by the radiation weighting factor for the specific radiation type. Thus, the absorbed dose in Gray averaged over an entire organ and multiplied by the radiation weighting factor gives the equivalent dose. The unit for the quantity of equivalent dose is sievert. The effective dose is a weighted average of the doses to all exposed organs, taking into account varying radiosensitivities of the different organs. The effective dose is the uniform whole-body dose that results in the same stochastic risk as the absorbed dose from any given non-uniform exposure, such as a CT examination of the abdomen. The effective dose is measured in sieverts. The risk of cancer induction from an equivalent dose depends on the organ receiving the dose. A method is required to permit comparison of the risks when different organs are irradiated. The quantity effective dose is used for this purpose. Thus, the relationship is equivalent dose in sieverts is equaled to the absorbed dose in Grays times the radiation weighting factor. A number of special dose quantities have been developed to characterize the doses associated with CT. They include the computed tomography dose index, referred to as the CIVIL, the volume CT-DI, the multiple scan average dose MSAD, size-specific dose estimate SSDE, and the dose length product DLP. The computed tomography dose index is the primary dose measurement concept in CT. CT-DI represents the average dose in a phantom along the Z direction at a given point, X or Y, in the scan plane over the central scan of a series of scans, when the series consists of a large number of scans separated by the nominal beam width, for contiguous scanning. Here are a few points about CT-DI volume to remember. CT-DI volume is an index. It is a dose in a phantom. CT-DI volume has many good uses, such as it is a good measure of scanner output. It is a good index when comparing protocols and technical parameter settings. And CT-DI volume is also a very good indicator of how scanner output is being adjusted with patient size. In this instance, think about pediatric protocols. Please remember that CT-DI volume does not account for patient size, and it does not represent peak dose. Although useful as a measure of scanner output, CT-DI volume should not be used as an indication of patient dose, because it does not take into account the size of the patient to which the dose was delivered, and therefore does not reflect patient absorbed dose. The dose length product, or DLP, is the CT-DI volume multiplied by the scan length, which is the slice thickness times the number of slices in centimeters. It should be noted that the DLP is independent of what is actually scanned. In other words, the reported DLP is the same whether a 10-pound infant or a 100-pound teenager is scanned, if the scan length and the other scan parameters are the same. Conversion factors can be used to estimate what the effective dose equivalent would be. However, these conversion factors are problematic in that they are only estimates of dose and do not represent the full range of pediatric sizes. The size-specific dose estimate, or SSDE, is a metric that accounts for patient size, scan length, and tissue attenuation. It was introduced in 2011 by the American Association of Physics and Medicine in Report 204 as an indicator of absorbed organ doses. That paper presented a set of conversion factors called F factors to take clinicians from CT dose index volume to a better and more accurate estimation of patient dose. Between 2011 and 2012, at least a dozen studies have been published describing the use of size-specific dose estimates in clinical populations. Please note that the two related measures of CT radiation dose that are available on CT Councils are the CT dose index volume and the dose length product. The CT-DI volume represents the radiation dose of a single CT slice and is determined using acrylic phantoms. These acrylic phantoms are cylinders of a standard length and are generally in diameters of 16 centimeters and 32 centimeters. The dose length product, DLP, is the CT-DI volume multiplied by the scan length. That is, slice thickness times the number of slices in centimeters. Radiation exposure is related to the amount of ionization of air produced by an X-ray beam. It is a radiation source-related term and is a measured quantity. Radiation dose is a body-related term and is calculated from the exposure. For a given measure of radiation exposure, we can specify the amount of radiation energy deposited in the patient's body as a result of that exposure. The goal of dose management should not always be dose reduction. A balance must be struck between dose and image quality. That is, a balance must be struck between the principles of ALARA and AHARA. The image quality portion of this balance is much more intangible in nature than the dose side. Basically, image quality has physical or objective properties such as model, contrast, and artifacts. The main goal of dose management is to limit diagnostic radiation exposure in CT. In order to do this, you must do the right study correctly and at high quality the first time. Let's take a look at radiation in CT. Radiation in CT originates from the X-ray tubes. There are localizer scans, which have relatively low radiation exposure to the patients. These scans allow us to make sure we are going to image the anatomy required by the requested study. The diagnostic scans produce the bulk of the radiation dose to the patient. Therefore, it is very important to understand correct patient positioning for a CT exam. Properly position the patient the first time and use the localizer scans to carefully define the field of view for the diagnostic study. Try to avoid repeat scanning. In producing a CT image, both MA and KVP must be carefully chosen to ensure sufficient delivery of X-rays to achieve acceptable image quality at a radiation dose that is as low as reasonably achievable. Kilovolts peak selection. The selection of KVP sets the energy of the X-rays reaching the patient and should take the scanned object into consideration. Each object will vary in density and in atomic number, both of which will impact the X-ray beam's attenuation. Larger, denser objects will require higher or more intense KVP selections to ensure a sufficient number of photons exit the object and are subsequently captured by the detector. Kilovolts peak, or KVP, controls the quality of the X-ray beam produced. KVP controls the contrast, or grayscale, of the resultant image. There is an inverse proportion between KVP and contrast. That is, the higher the KVP, the lower the contrast. We call it kilovolts peak due to the fact that if we chose a particular KVP, say 100 KVP, you will also get some voltages that are slightly above the chosen KVP, or maximum kV set on the control console, and some voltages that are less. You will get a range from about 98 to 102 KVP generally. The amount of tube voltage, or KVP, affects radiation dose. Reduction of the tube voltage will decrease the output of the X-ray tube and reduce the radiation dose to the patient. Inappropriate reduction of the voltage may result in a marked increase in CT tissue attenuation and noise, particularly in large patients. Most CT scanners offer a limited number of choices for KVP values when performing CT scans. Routine body CT for adult patients is generally performed at 120 to 140 kVp. The use of 80 kVp is a well-accepted level when attempting to reduce radiation doses in pediatric patients. Milliamp seconds, or MAS, controls the quantity of X-ray photons produced. The quantity of X-ray photons produced directly affects the patient dose. The relationship is as follows. The MAS is equaled to the milliamp, which is 1 1,000th of an amp, times the time in seconds. MAS controls the blackening, or density, on the X-ray film. There are several factors that affect the patient's radiation dose. These include CT scanner design, the scanner use parameters, such as KVP and MAS, pitch or speed at which the table is moving, dose optimization, automatic tube current control, and AEC, which is automatic exposure control, and ECG gating. Let's take a look at CT scanner design. On single-slice systems, the geometric efficiency is generally close to 100%. In current multi-slice scanners that we see, they have dose profiles that are 2 to 3 millimeters wider than the total image width. In general, wider collimations, commonly used, leads to dose increases of approximately 10% compared to single-slice systems. Take note that very narrow collimations can result in a tripling of dose. Scanner use parameters. User-selected parameters, KVP and MAS, determine the radiation dose to the patient. Multi-slice systems allow higher MAS, longer scan lengths, and multi-phase contrast studies that have the potential of increasing patient dose. Please note that scanning with narrow slices requires increased MAS to maintain acceptable signal-to-noise ratios and will increase patient exposure. The pitch is the speed at which the table is moving through the gantry. The absorbed radiation dose is inversely proportional to the pitch if the MAS and KVP remain constant. If the pitch is doubled, the scan time will be halved, and the absorbed radiation dose will be halved as well. On multi-slice scanners, if the imaged slice width remains constant, the noise will increase, thus necessitating an increase in MAS to limit noise in the image. Some systems automatically adjust the MAS to compensate for noise. Dose optimization. Patient dose is dependent on KVP, MAS, rotation time, focal spot size, selected field of view, slice width, and pitch. Careful attention to all of these factors will limit patient dose as much as possible while yielding diagnostically accurate images. Now we will discuss automatic tube current control and automatic exposure control. More advanced AECs have the ability to adjust tube current based on actual patient attenuation. The system uses a planning scan projection radiograph, SPR, or SCOUT to adjust the MAS for each tube rotation. This SCOUT is derived from the localizer scan. On older systems, it is important to reference age or weight-based tables of exposure settings. There is no one-size-fits-all when it comes to exposure settings. Examples of automatic exposure control packages include GE's Smart MA, Philips's Dose Right and DOM, and Siemens CareDose 4D. ECG-gated cardiac studies. Significant dose reduction can be achieved when imaging the heart by using ECG gating. With this technique, images are only acquired at full exposure during the relaxation phase of the cardiac cycle. Optimizing dose in a clinical setting is a tough call. Ramp up the MA by 100 and the radiation dose doubles. Increase the KVP from 80 to 140 and the radiation dose goes up 4 times. On the other hand, if MA is modulated, it impacts the noise in the image. And if KVP is modulated, it affects the attenuation of tissues as well. This calls for a balancing act where the image quality is not affected and the patient is not overdosed either. If we want to keep patient radiation exposure as low as reasonably achievable, one-size-fits-all type protocols must not be used for any CT scanner. The guiding principles for radiation protection in medicine are justification. The exam must be medically indicated. Optimization. The exam must be performed using doses that are as low as reasonably achievable, consistent with the diagnostic task. And limitation. While dose levels to occupationally exposed individuals are limited to levels recommended by consensus organizations, limits are not typical for medically necessary exams or procedures. The guiding principle for dose management in CT is that the right dose for a CT examination takes into account the specific patient attenuation and the specific diagnostic task. For large patients, this indeed means a dose increase is consistent with ALARA principles. Additionally, each CT exam must be appropriate for the individual patient. Justification is a shared responsibility between requesting clinicians and radiologists. Hence, for medical exposures, the primary tasks of the imaging community are to work with ordering clinicians in order to direct patients to the most appropriate imaging modality for the required diagnostic task, as well as to ensure that all technical aspects of the examination are optimized such that the required level of image quality can be obtained while keeping the doses as low as possible. When used appropriately, the benefits of a CT scan far exceed the risks. CT scans can provide detailed information to diagnose, plan treatment for, and evaluate many conditions in adults and children. Additionally, the detailed images provided by CT scans may eliminate the need for exploratory surgery. Concerns about CT scans include the risks from exposure to ionizing radiation and possible reactions to the intravenous contrast agent, or dye, which may be used to improve visualization. The exposure to ionizing radiation may cause a small increase in a person's lifetime risk of developing cancer. Exposure to ionizing radiation is of particular concern in pediatric patients because the cancer risk per unit dose of ionizing radiation is higher for younger patients than adults, and younger patients have a longer lifetime for the effects of radiation exposure to manifest as cancer. However, in children and adults, the risk from a medically necessary imaging exam is quite small when compared to the benefit of accurate diagnosis or intervention. It is especially important to make sure that CT scans in children are performed with appropriate exposure factors, as use for exposure settings designed for adults can result in a larger radiation dose than necessary to produce a useful image for a pediatric patient. Dose reduction strategies. The primary strategy for keeping patient radiation exposure as low as reasonably achievable is by performing the proper examination with the highest quality on the first attempt. Utilizing AEC and age, weight, and size charts for suggested KVP and MAS settings is very important in our efforts to limit patient radiation dose. Please remember there is no one-size-fits-all for exposure parameters on any CT system. Carefully review the patient's prescription for proper indications for the diagnostic information being sought. Discuss any questionable orders with the supervising radiologist for clarification. Limit the scan field of view to the orders as written by the prescribing physician. Another dose reduction strategy is to always take the time to explain the procedure to the patient and the need for their cooperation. A few well-placed words can avoid repeat studies and the resultant increased patient radiation exposure. Please take a moment to review this chart of radiation dose comparisons for standard chest X-rays all the way up to CT of the abdomen. The time period for equivalent effective dose from natural background radiation is also shown. Some would find this information quite startling. As a side note, remember that you can pause this slide if you need more time to review this information. The following references were used in the preparation for this webinar. Thank you for joining us today. We hope you now have a better understanding of radiation dose in CT. Please remember to take the test, and also remember you must score an 80% or above in order to receive a certificate.